So my name is Shiv, and thank you for having me. First of all, I want to thank the University of Maryland for the nice invite. As Catherine mentioned, I'm a medical student at Johns Hopkins who's currently taking time off to work on a startup in Philadelphia. So on the train ride back to Baltimore, I felt a nice homecoming. And I think what I like to do is I like to bring things to presentations. I think my elementary school teacher got me hooked after the first show and tell. So throughout my presentation, I'll start showing you some gadgets. And let me just pull up the presentation. So the title of the talk is a question. It's, are these mobile medical devices and apps just toys or gadgets, or will they actually be disruptors of healthcare? And the perspective I'm bringing in on this first and foremost is as an editor of a medical technology blog called mHealth. So I do think all of them are gadgets, but I see them transitioning to be actually useful tools that clinicians and patients themselves can use. At the beginning of this year, Forbes called 2013 the year of digital health. And it was a bold proclamation that has come true for a large part. I think this year, when we look back on it, will be an inflection point, and when patients became more engaged with their own health and clinicians started actually prescribing things like apps and other interventions. One example is, I don't know if any of you have heard of the Scan Scout. It's billed as a medical tricorder. VentureBeat covered this a few months back. They broke Indiegogo's fundraising record at 1.37 million and since raised 1.61 million. And now Indiegogo is famous for launching bands and books, not necessarily medical devices, but normal patients started funding this because they really care about their own health, and we're seeing increasingly these B2C or business to consumer applications of mobile health apps and devices. These slides are from Rock Health, which is a digital health incubator out in San Francisco. They're one of the most active ones. And they said that by June, 90 of these companies had raised over 2 million, with the top digital health company raising about 43 million. And that's a medication adherence app that when you take a pill, it actually transmits to your phone that the patient has taken a pill. So it's very high tech, very interesting, and they raised, I said, about 43 million. And the amount of fundraising has increased since 2011 pretty dramatically. In 2011, it was 890 million. 2012, it went up to 1.4 billion. And in 2013, it's already 12% higher. And this has shown no signs of slowing. And I think this is the last slide I'll show from Rock Health. This isn't just an overall increase in investment and excitement in the healthcare industry. As you can see here, healthcare funding for medical devices is actually down about 30%. Whereas software and digital health funding is up on both sides. So as I mentioned, I bring in the first perspective as an editor of a medtech blog, which is decently trafficked. It's all clinicians, clinical students, or biomedical engineers who write for this blog. But then my day job was as a student at Johns Hopkins School of Medicine, and so this was my nerdy version of the Clark Kent Superman, where during the day, I was, again, learning how to treat patients, learning about the physical exam, and then during the night, I was writing about innovations in medical technology and what I see when I'm actually able to practice and prescribe things that I'll be using, where I know there's a cardiologist named Dr. Eric Topol out in Scripps who often talks about these devices and this revolution. He wrote the book, The Creative Destruction of Medicine, and he says that he prescribes more apps than he does pills at this point. I think when I'm actually practicing, I think that'll probably be close to the case, hopefully. And so what I noticed was that as I was learning how to do a physical exam at Johns Hopkins, many of the maneuvers I was learning were able to be recreated by mobile health devices and apps. So things like taking a blood pressure on a patient, there was a device that came out for that. The heart rate, same thing. And I'll go through some of these. And it got me thinking about this concept of how many basically the question, can we do a physical exam, a complete physical exam, just using a smartphone and some attached devices? And so that's how the idea for the smartphone physical was born. And MedGadget was approached by TED Med, which is a popular technology conference held in DC every year, to curate a showcase. And so I decided that this would be probably a great debut site for it. And so to give you an overview, there was a 90-second Associated Press video And then I'll go into dissecting it as a case study for what's happening in digital health and mobile health.
Your eyes may widen too if your next physical was partly done on your smartphone.
Here you can see the arteries on the back of your retina.
What if you had an earache?
And I'm going to be looking at your ear.
High blood pressure?
Now I'm going to hand this to you, and I'm going to let you push the button.
Your own doctor may be the next to say, there's an app for that. There's a growing list of medical devices that attach to smartphones and sync with apps. You can capture images of the inner eye and eardrum, take readings, and track data to give doctors and patients health information. Most are for iPhones, and essentially turn them into an
ophthalmoscope, otoscope, stethoscope, ECG, and ultrasound.
Shiv Gidlani, a med student and gadget expert, brought some tools together at the TED-Med conference. Not all are FDA approved yet.
I think we'll see over the next few years a proliferation of more of these devices in the exam room.
Some devices, like a plug-in blood pressure cuff and digital scale, are meant for patients at home to monitor themselves daily, notice trends, and spot changes.
What we're doing here is meant to improve the patient-doctor relationship and turn patients into their own good data collectors.
Data and images can be emailed, perhaps reducing office visits, or helping doctors in underserved areas treat patients and consult specialists.
These devices are very portable and very compact, and in many cases they actually give better images than our traditional tools.
But physicians warn, don't base medical decisions on Dr. iPhone alone. See your real doctor too. Noel Wagner, the Associated Press.
After that video came out, I considered making business cards where it said med student and gadget expert. So the smartphone physical, what exactly did it consist of? We had 9 devices or apps that did everything. Well, I'll list them. They did everything from, this is a wireless body scale analysis, so it's your weight and your, you can get your BMI too if you get your height. This is a blood pressure cuff, a pulse oximeter for your oxygen saturation. This is a spirometer, and this, unlike the other device, other things in the smartphone physical, was purely based on the iPhone microphone and some pretty sophisticated waveform analysis. So it didn't require an external sensor. It was just an app. This is a case that goes around an iPhone 5 and turns your phone into an otoscope. So anyone who's a parent probably would see the immediate utility of this, and I'll discuss why. This is a case, it's an iPhone case also, and it's, many of you may have heard of this if you're following the area. It's called the LiveCore ECG. Basically 2 electrodes where if you hold it like this on your hands steady, you can get a 1-lead ECG recording. This is the Welch Allen ophthalmoscope. So this is normally what physicians use. It's an ophthalmoscope, but what they've added is a case that turns your iPhone 4 into the image capturer. This is an ultrasound machine that plugs into just a probe that plugs into a Windows-based phone. And finally, this is a stethoscope that can transmit the actual waveform, so like the phonocardiogram or the respirogram, to your phone screen. And the reason I laid this out in 3 columns, this is the rough order in which we did the exams, but the first takeaway is I think that there's a difference between the tools and their utility based on who's using it, who's the end user. I see the things on the far left as being things that patients would use, and things on the far right as being what providers will use. If you consider the things on the far left, that's weight, blood pressure, and oxygen saturation. These are more helpful if you get trended measurements. You know, you can't. So I like to give as an example. If I was wearing a white coat right now, I think the average blood pressure in this room may be 5 to 10 points higher. Because when you go and see your physician or your nurse and they take your blood pressure and they're wearing a white coat, it's been shown that there's this phenomenon called white coat hypertension. And if you're basing treatment decisions based on snapshots of these indicators, it's not as useful as perhaps patient trended data, where as long as the need, basically the technology to get this blood pressure data is abstracted and made so easy that anyone can do it, then we can get decent data trended over time and then make actual clinically relevant decisions based off of it. The things in the middle I see as being partly providers and patients. These are things that patients don't need to do every day, for example, like weight or blood pressure, but things that could be used by patients at home on an ad hoc basis. So the otoscope, I think, is a perfect example where you don't want to be taking pictures of your eardrum every day, but if your child has, say, an earache and it's 9 p.m. and you don't want to go to the ER because that's one reason healthcare costs are so expensive. and your pediatrician is busy or away, you can take a picture of your child's eardrum yourself, if you just have one of these cases, transmit it to a pediatrician maybe halfway across the world, and they could do a read and then send over a prescription that you could then fulfill and get an antibiotic to treat your child's eardrum. Same thing with the ECG. This could be used by providers or patients. So providers as a screening tool and patients as like an event monitor. And then the things on the far right are not only more expensive, but they're a little more complicated to use. They are becoming a little easier to use, but I still don't see patients as needing these. The joke we said at TED Med was that there's a family or a soon-to-be family that wanted the Movisante ultrasound system. So a woman was pregnant, and her husband asked us if we could sell them the Movisante right then and there. And so I think these people are probably going to be helicopter parents because they apparently wanted to do ultrasounds at home of their baby, and that would probably be harmful. So we wouldn't want patients to be equipped with some of these devices. So there's 4 reasons I think these devices indicate a disruptive potential for healthcare. The first is a lower cost. So the lowest cost bedside ultrasound system that I've seen is about $20,000 to $25,000. This Movisante ultrasound costs about $5,000 to $10,000. So it's almost an order of magnitude less expensive. And the reason is, well, of many reasons, is that basically the major cost is in the probe. It's expensive to make the crystals that vibrate to generate the ultrasound waves. What this has done is it's abstracted away the processing power, the transmitting, the battery, and other things that you would have to build into a medical device if you didn't have the phone as the hub of that device. So things can become a lot cheaper, especially as more sensors get put into your phone. Broader access is another thing, and this is not only because things are becoming cheaper from the first point, but also because they're becoming just generally easier to use. This pulse oximeter, you can just plug in, just like you'd plug in a charger to your phone, and then put it on your finger, and you could track your oxygen saturation over time. You can imagine that people with chronic diseases like COPD could potentially use this at home and track their oxygen saturation over time as well. A third disruptive potential is big data, and I use the weight scale here because not only are we getting more data, but some of the data is unfortunately getting bigger in value. And so the big data aspect of this is something that's talked about a lot in the media, that if we can trend people's measurements over time, then we can abstract it away so that it isn't physicians who necessarily, or clinicians in general, who have to analyze reams of data. It can be machines that do that, so machine learning. That's how Netflix recommends TV shows to you, and that's how these devices could potentially spot a congestive heart failure patient who's gaining 5–10% of weight because they aren't taking their diuretics or eating too much salt. And then free data, and I don't mean free in the sense of like a free beer or a free sandwich. I mean free in the sense of it can move between devices. So the SpiroSmart app is the perfect example of this, where it basically takes data generated by your trachea as you're exhaling air. That's transmitted. That sound wave is transmitted to your phone mic. The iPhone then takes the raw data, submits it to the cloud, where it's analyzed at some servers at University of Washington in this example. And then within 10 seconds, it sends you back a flow volume diagram and FEV1, FVC ratios. And so this data has moved across the world and come back to you with clinically relevant interpretations in the span of 10 seconds. And so this is incredibly powerful where, again, it isn't the patient at home trying to track their values, it's the data flowing between devices. And really the biggest barrier to this is, I think, political. It's electronic medical record companies and other companies not necessarily wanting to share their data. Even some medical device companies may not want to do so, and there was a Wall Street Journal article about this with respect to companies that build pacemakers not wanting to share that data, because they now with the commoditization of medical devices and how cheap these devices are becoming, we're entering a data economy. So the data itself could be turned into money, and that's the business model of this company, where this device is $199. It's pretty cheap. But every time a patient wants a read, they're probably going to set up something where there's a per read fee. So I just want to go through really quickly 5 applications. I'll skip some because I think our panelists will be able to talk about it in more detail. But the first is screening. So I think with more portable and cheaper devices that can be used be democratized and given broader access to, screening is something that can benefit immediately. Many people probably here have had a 1280 EKG, which is a time-consuming process, but it's the gold standard for being able to detect any heart abnormalities. But there are certain heart arrhythmias like atrial fibrillation that you can get a good sense of with just the 1 lead EKG. And so that's what this team's trying to do. They had a recent success clinical trial called Search AF, where they basically gave this device to pharmacists across Australia. And whenever a patient above 65 years of age entered the pharmacy and was picking up their medication, they were given a quick 60-second read on the EKG. And then that was interpreted by an electrophysiologist who found that 10 of the patients, so 1%, had undiagnosed atrial fibrillation that was so severe that it could potentially result in stroke, and these patients were then prescribed oral anticoagulants. So there's a double-edged sword here where if we do too much screening and obviously lead to many of these people getting overtreated, it could not be cost effective, and then you've kind of negated the effect of cheaper devices. But in this particular study, they indicated that this was economically viable. A second is telemedicine. So this is Eric Topol using the Cellscope otoscope on Stephen Colbert. And I already discussed the application of a parent at home trying to use this and transmitting the data. So not having to go to the office or set up an appointment for a quick otoscopy exam. Third application is global health, and none other than Dr. Labrik is here, so I think I'll let him take this application. Fourth application that isn't talked about much is education. And I know there are a lot of clinicians in the room. How many of you have ever looked at an optic disc? You can raise your hand if you ever looked at an optic disc. And so you use a device like this or one of the ones on the side of the clinical exam room. Now, when I was training on how to do this was at Wilmer, and there's some really great professors and ophthalmologists at Wilmer. There were 5 medical students and 1 doctor who basically did the do one, I forgot what the, it's like see one, do one, teach one, right, in medical education, where I saw him use this device on a patient, and then he gave it to me and asked me to do it. And I was going, he was directing me. He said, have the patient look over your right shoulder, go at a 45-degree angle, hold their eyes open like that, and then when you see a vessel, trace it back to the optic disc. And it sounded very easy until I actually was given the device. And after the 3rd time he asked me if I saw the optic disc, I just nodded and said yes. And I know that 4 out of the 5 students did the same thing, because we weren't able to see exactly what he meant. And it seemed, nobody wanted to be that medical student who couldn't find the optic disc. And so what this does is it essentially aligns the camera to the optics in this ophthalmoscope, and we've been able to get very vivid pictures of optic discs. And as an educational tool, the physician or nurse could actually have it on their screen and then go into the eye and show you what they're doing. And then when they give you the ophthalmoscope, you could do it and they could be commenting on your approach. More importantly, you could then take a baseline image picture of, say, a 25-year-old who has no visual symptoms, but then maybe 30 years later they do. But at that point, they don't have a baseline image. Instead, they only have something in their note that says WNL within normal limits or unremarkable. So I think with more data, we're able to get better images and store those so that later on we can tell, was this person who has glaucoma type symptoms, do they have like a disc ratio congenitally, or do they develop that over time because of glaucoma? And the 5th application that I think is most the holy grail is patient engagement. So there's a comic here which shows that a physician who didn't even ask this patient why they're there, they're just launching into the physical exam. And I use this Whiting's cuff as an example of how to improve patient engagement. Somebody earlier asked about behavior modification. I see mHealth and digital health being able to improve behavior because of a simple formula that B.J. Fogg, a Stanford behavioral scientist, put forth, where he says behavior is motivation, ability, and trigger all at the same time. And so this is a chart that he draws where on the x-axis is ability and on the y-axis is motivation. And most behaviors you can think of fall into this chart. So things like quitting smoking and losing weight, things that we want all of our patients to do, are sometimes the patients have high motivation, but a very low ability, so it's very hard to do. And unless they cross this activation threshold, triggers won't really help them. They'll just feel like, they'll yo-yo diet, or they'll try quitting smoking for 2 weeks and then be recidivists. I think it takes, on average, 5 times for somebody to quit smoking, or something along those lines. And so what these technologies do, and what BJ Fogg prescribes, is he says don't focus on motivation, because people's motivations are too mercurial, or too fickle. My motivation changes day by day, if not hour by hour. Especially after 6 hours of class or lecture, I don't really want to go to the gym, which is why I do it in the morning. But with motivation, again, being too fickle, he says we can increase people's ability and shift them over to the activation threshold, just to the right. And that's things like automated data trackers, where you don't have to worry about logging your blood pressure, but your phone will do it for you. And then being able to, I've gone to clinical visits where the patient's managing their hypertension and keeping the blood pressure records or their weight records, but they forget to bring it in that day because it was written on in a notebook. So how do we improve our patients' ability to engage with their own health? And I think these devices will help improve that. Right now, we're very much still in the early market, in the visionary stage of the technology adoption life cycle. We still have this chasm to cross, but I see 4 steps required to be able to actually cross the chasm. And this is my second to last, or third to last slide here. To cross the chasm, basically put another way, how do we transition digital health technologies from toys to tools? And so I call this the stairway to digital health, where it's four different steps that aren't necessarily in chronological order. But the first is just awareness. It was astounding how many times I would write about an innovative medical app or device, and then go to Johns Hopkins and tell my clinician mentors about it, and very few of them even knew about it. Still, I feel like very few people actually know about this device and kind of its transformative potential. And so just things like continuing medical education or nursing education will raise awareness for that. The second is compliance. I think the apps and devices that will succeed will be the ones that actually seek to be more than just fitness trackers or things that will be clinically relevant. So whether or not they need FDA approval and they pursue it is of importance. Evidence is another big thing. Nobody wants to prescribe something to their patient that could harm them or is not cost effective or will improve their patient outcomes. So a lot of these device manufacturers are now publishing in things like different journals, and I recommend all the device companies I talk to and work with to try doing so. And the last is reimbursement, and this is the highest because it's probably the hardest and most unknown right now. In June, the first prescribable mobile app was approved. So the barrier has been crossed, and again, I think 2013 is an inflection point, but it'll be unclear about who's going to be paying for these devices and then say the data reason and whatnot. So with that, the last thing I wanted to just do is point out that these devices people are innovating and creating new devices all the time. One thing I will point out, on the far right, that's a smartphone-based PCR system. So if you go to a global health setting and you want to test somebody for dengue or some other disease, you have your phone and you can do a PCR on it now too. And there's a breathalyzer on the bottom left here, which could be fun for parties, but more importantly for helping to prevent people from driving drunk. And so with the last, just wrapping up, the last things, if you guys are interested in talking more about digital health tools or interested, maybe some of you have ideas for what you want to create, I'd be happy to talk to you. This is my email address, and you can follow me on Twitter right there and engage there. So thank you for your time, and wish you the best of the conference.
So I think that was a great talk. Thanks, Shiv. And you talked about being Clark Kent by day and Superman by night. I think I'm always Clark Kent. I can't seem to transition. So I'll show you why, because I brought with me this technology that's years ahead of what Shiv just showed you. And for those of you who go back a few decades, you know what this is, right? And for those of you who are in the dark, the next slide will shed some light onto that. About 40 years ago, Commander Spock of the USS Enterprise was demonstrating the use of this tricorder device, right? A single handheld device that would allow you to communicate with the mothership miles and miles away, to do on-the-spot diagnostics of patients, and to be able to identify disease conditions long before they became so severe that the patient was on death's doorstep. So here we are today with Qualcomm sponsoring another challenge, the X Prize, where students around the world are being challenged to develop this new technology, where on a single platform, they're being asked to be able to diagnose multiple disease conditions, identify pre-chronic disease states, and really push these limits that she really laid out for us this morning of where we can go with these technologies in hand. You can see here the requirements of this competition are quite steep, where you have to be able to diagnose and identify elective conditions using this smartphone device. So I know Hopkins has a design team with about 100 students working on this. I'm not sure if University of Maryland does as well, but it's just phenomenal to see where we are. But I'm going to switch a little bit the tone of the conversation and talk about what mHealth represents for those of us working in global health. And as a global health practitioner, as an epidemiologist, this is the traditional view of the world, where the boundaries of each country have been modified to represent the proportionate disease burden, mortality and morbidity within those particular countries. And you can see it's why so many of us work in sub-Saharan Africa or South Asia. But there's actually another paradigm shift that we've seen occur, and then this morning we heard a little bit about that. But when we think about the global coverage of mobile phones, the cell phone revolution, as it were, that we are observing as we go through our projects and populations in these resource-limited settings, we see today that the International Telecommunications Union has announced that there are as many mobile phone connections in the world as there are human beings. And we're just a little less than 150 years from that first phone call that was made by Alexander Graham Bell and his colleagues. So we're talking about over 75% of the world now having access. So here's another view of the world that I'd like to put up, and I apologize for the graph. You can see it better on the side screen. But this is just a fraction of Facebook users around the world connected to their friends. Only 10 million of the 850 million or so Facebook users. And in the total absence of political boundaries, we see the globe itself emerge, demonstrating how these connectivities with the technology. Facebook, if you talk to someone about Facebook in rural Botswana or Bangladesh 5 years ago, they would have looked at you askew, wondering, what are you talking about? Today, amongst our 850 field staff in rural Bangladesh, I have about 100 Facebook friends. I'm not sure what to do with them, but nonetheless, they exist and they're using this technology. So for me, mHealth is about being untethered yet connected. That's really the definition that I find to be the most appropriate to identify why we find this to be so exciting. I also start by explaining to my students when I talk about mHealth that there really is no such thing as mHealth. And I think that's one message that I'd love for folks to take away from today, that mHealth is a diversity of solutions. It's applying this potential strategy to a range of obstacles and constraints that face us, whether we're practicing clinical care or global health. So from education, as Shiv just pointed out, to diagnostics, all the way to remote data collection, supply chain management is one of the core use cases where mHealth strategies have been transformative in the way that malaria drug supply chains are managed and maintained in sub-Saharan Africa. For me, it's about 5 C's. The first is, of course, the most basic function, collecting data. And as previous speakers pointed out, without good data, good decisions are always impaired. Counting events is also a crucial action in global health. Whether you're looking at denominators or numerators, it's essential to be able to count populations with which you work. But really, this other function of connecting individuals, I think, is a core opportunity that we have in the global health space. In public health in general, it's that connection between a patient and the provider, the connection between a community health worker and her clients that opens up those new windows of opportunities to compress time. Whether you're in nursing, emergency medicine, clinical care, or public health, compressing time is what we do. It's reducing the risk period, the risk exposure of individuals, whether it's to infectious diseases or to road traffic injuries, is where we really want to act. And then finally, this opportunity, the creation of novel opportunities, novel windows of time in a patient's experience or in a population where we can act. For example, in rural Bangladesh, we now get birth notifications via text message, which reduces that time, opens up a totally new window of opportunity for us to go into a home and ensure that the basic essential newborn care measures are being taken to improve the survival of that newborn. But we know that there are hundreds, not dozens, but hundreds of cost-effective and efficacious ways to reduce maternal and neonatal mortality on the global health landscape. There are books and books from WHO that outline these guidelines, that review the evidence, do meta-analysis of the clinical trials that support these packages of interventions across these various levels. The challenge for us in the global health space is how do we take these interventions of known efficacy and scale them to reach effective coverage? And that's really the sum of the problems that we face in many of these contexts. We find potholes along this road to effective coverage, whether they be stockouts, whether they be failure to follow guidelines, lack of performance tracking, incentives, motivation. And it's mHealth that we see as a way of bridging these potholes in our journey towards effective coverage. Recently, we published an article in the Global Health Science and Practice Journal helping innovators like Shiv and colleagues who are in the space of technology innovation to transition from speaking about technologies. Often when mHealth innovators go to meet the Minister of Health of a particular country, they get pushed to the side and said, join the line of pharma reps that are sitting out here because I know you're trying to sell me another widget or another technology that's going to solve all my problems. What we've done with these discussions with WHO and UNICEF is to say, how do we transition from talking about technology to talking about health systems? Identifying where along the reproductive health continuum you're actually intervening and what it is you're doing, simplifying mHealth into what we call the 12 common mHealth applications. So are you doing client and behavior change communication? Are you helping to create registries for vital events tracking? Or are you helping with supply chain management? This is the language of health systems, which can help neutralize some of that anxiety when an mHealth innovator walks into a room and starts to talk about widgets and devices. And so we promote this idea of technologic agnosticism, as it were. Here's another matrix we developed, which is sort of mapping out the constraints, helping people to focus not on the solution, but on the problem. Articulating the exact problem that you're dealing with in global health is the first step in that conversation towards the solution. And I find many of those discussions are disrupted in the global health space because people jump in starting to talk about the solution that they have in hand, the tricorder device, if you would, without really clarifying what problem it is or what constraint it is that you're trying to solve. So let me give you a few snapshot examples from our field site in northern Bangladesh, where we've been working now for about 13 years. We followed in this population in the north of this country about 130,000 incident pregnancies over the past decade. To bring home this point of why we're conducting mHealth research in rural resource-poor communities, I should like to show this picture, because to me this is my motivation when I wake up in the morning for going through my day. An empty Boeing 747 representing the total number of women and pregnant women and new moms that die every 2 weeks in each country in South Asia, Bangladesh, India, Nepal. So the burden of mortality, the urgency of this issue is severe, and why we need to act, even where there's no health or mHealth, as it were. So earlier in 2012, we did a survey of this rural population where we've been working. 71% of households report owning phones, even though only 23% of these homes have electricity. So that the boardroom obstacles that we face when we're sitting here in Baltimore thinking about what can we do in rural Ghana or rural Bangladesh or India are often already solved when you get to the field because of the attractiveness of mobile technologies in this population. We asked pregnant women who felt that they nearly died. We had about 50% of women who had near-miss events use a mobile phone to mobilize provider care, request advice, or even mobilize financial aid during those crisis moments of pregnancy in this rural, remote population of Bangladesh. We tried something crazy because all the formative research that we had done said you will not be able to get women to tell you when they're going into labor. Because if you want to intervene on neonatal mortality, it's imperative that you are there in the home when the delivery is happening or in the hours after that birth. we gave women a short message to send us when they were going into labor, and 90% of 500 consecutive pregnancies informed us that they were going into labor in rural Bangladesh. So telling us that what you can dream of can sometimes be accomplished even under these low resource settings. This is an example of a system that we're now testing through a randomized trial in northern Bangladesh, where we are allowing community health workers to do these basic functions of census enumeration, pregnancy surveillance, and then sending antenatal care reminders to their clients automatically through a server-based systems. These are not complex technically, but they are transformative in terms of engaging clients in the public health system in these low resource settings. But more importantly, the ability of families to send us these labor and birth notifications really changes our ability to act during these critical windows of time, so that we can mobilize referral and support during this period. We're working with the Ministry of Health in Bangladesh to develop a virtual vaccine registry. I'll show you the picture of a vaccine card only 3 months after it's been issued. Now, this is the only place a family has a record of its child's vaccines in this rural population, and it's much the same across most of South Asia. But now, through this system that we're working with the government on, a woman or her family or a pediatrician can text message into the national server the child's unique ID and receive a digital version of that electronic vaccine record just by requesting it. But we also are able to target barriers and challenges to getting women to come to care and receive those vaccinations on time using these mobilization systems. Simple text messaging. We often forget that voice and text are some of the fundamentally transformative systems in these low resource settings. We're working right now with the USAID and the Ministry of Health to develop a population vital event system where if you record the word death to a standard ID, it takes you through a decision tree to allow you to report whether the death was an adult death or a child death, the age of that death, and whether it was a male or a female. Basic population statistics that are largely absent in most of the developing world. So let me give you a quick snapshot of the landscape of mHealth. There are not just hundreds, but thousands of mHealth pilot projects around the world. Someone said recently, there are more pilots in mHealth than there are in the US Air Force. And to some extent, people criticize this, but I think it's also a good thing. Because as Chief points out, it demonstrates to us what is possible. So Mama, a project that is largely inspired by our next speaker's presentation, the Text for Baby program, is now in 4 different countries, sending pregnant women text messages about healthy pregnancy behaviors and neonatal care. In Ghana, where fake drugs have proliferated throughout the market, and in places like Nigeria, make it extremely challenging for folks to go to a pharmacy and buy legitimate drugs, you can now text message in the barcode on your drug strip and find out whether that's in fact a valid strip of medication or not. Frontline SMS, a system that anyone in this room can download at the end of this lecture, and set up a patient reminder system to take complex regimens like ARTs when diagnosed with HIV. At Hopkins, we're helping to develop some of these low-cost sensor-based technologies where one of the simple diagnostics that's required in pregnancy is hemoglobin, to understand the risk of a pregnant woman in going into that delivery period. Using not a smartphone, but I hate to call them dumb phones because they're a whole lot smarter than some other technologies, but they use the audio jack of this phone to process hemoglobin measures coming from a very, very low-cost device. And they were recently awarded by the Gates Foundation a pilot grant to help develop this further. Folks at Stanford are using this phenomenal camera that is now embedded in most smartphones to conduct screenings of the buccal surface to look for precancerous lesions. Again, enabling this critical measure of task shifting, where highly trained clinical resources are scarce. Being able to shift those tasks to frontline health workers is really innovative transformation in global health. We're working with WHO on taking some of these kilograms and pounds of ledgers that basically get filled up and then put on a shelf across much of the developing world into digital tablet formats where pregnant women can be tracked in real time not only contributing to national health records, but also allowing that frontline health worker to target care to high-risk pregnancies based on data-driven issues. But they can also use these platforms for patient counseling, transforming the traditional flip chart systems into these interactive videos, showing people videos of anatomy, showing people correct use of condoms, and other things that really change the way that dialogue takes place. In rural Bangladesh, where it's a conservative Muslim community, we can't say the word breast in a conversation. But showing someone a video about a breast cancer survivor opens up that room for dialogue, where we can now begin to talk about the appropriate steps of screening for this disease that costs so many lives in this rural population. But we've heard about these remote diagnostics and other exciting frontiers, point of care and remote monitoring systems that are gradually going through FDA approval and entering mainstream use. But from the global health perspective, it's critical to understand that mHealth does not work in a vacuum. We have to think in systems approaches. We have to think about downstream and upstream factors, whether these involve use of data, transport, financial resource mobilizations, functioning clinics, and well-trained staff, in order for that phone to actually have a transformative effect on the ground. Now, we saw a couple of really nice figures, and I think I'm going to add some of those to my repertoire, but this is one that I particularly like, the Gartner hype cycle. Whenever we introduce new technologies, we find ourselves rapidly spiraling up this peak of inflated expectations. We think this next technology is really going to solve things for us. But we often find ourselves slowing down that black diamond slope of to the trough of disillusionment. And I think that's where, unfortunately, many exciting technologies languish. And so I think the shared challenge that pragmatic public health technologists face is identifying the most promising technologies that are languishing in this trough and helping them up the slope of enlightenment into productivity. And that's through those steps that you just shared with us in terms of evidence, in terms of putting them through the grist mill so that we can demonstrate their efficacy. We often hear about this pilotitis. This is a map of Uganda where you see the number of electronic health record and other mHealth systems that were being conducted all at once in one country alone, none of which were talking to each other or interoperable, which led to the Ministry of Health saying, cease and desist. We appreciate your innovation, but we'd like more collaboration with the ministry and cooperation amongst yourselves. And this has now repeated itself in multiple countries across Sub-Saharan Africa and South Asia. So sometimes, to also go to Stephen Colbert, I find myself sounding like this gentleman. You know, what do we want? Evidence-based change. When do we want it? After peer review. And the reason is, you know, we've been harping on governments across the world, base your decisions on evidence. Don't just go with your brother-in-law or the fellow who's giving you a cut of the budget. So at WHO, we recently started this new technical advisory group known as the mHealth Technical Evidence Review Group. And there's about 6 more words added to the end of it, but that's typical WHO. But the idea here is to provide governments and implementing agencies with that evidence-based guidance for where to make investments using these technologies. At Hopkins, we formed the Global mHealth Initiative about 2 years ago. We now have 97 projects spanning the university that look at different ways of applying mHealth to practice. So I encourage all of you to go to jhumhealth.org and learn about some of the work that's being done by your peers and identify opportunities for collaboration. We're always open to collaborating with folks across the street or around the world. So if you're interested in mHealth, it's a great place to start looking. So I'll leave you with these few thoughts. One is, again, to reinforce this idea of technologic agnosticism. It's not about the technology, it's about the problems and the appropriate way of solving those problems when, especially, you're talking about global health. It's about identifying constraints and then looking for the appropriate opportunities to alleviate those constraints. We also need to take a systems approach, and that's really the paradigm shift that we're seeing in the global health landscape and dialogue. And understanding that behavior change is not easy. I mean, this is something we've all known for decades, but somehow we think that introducing this technology will somehow make behavior change easier. It's certainly not, and it's something that requires in-depth formative research and careful, rigorous evaluation. This is the reality of much of where we work in global health. This actually was a Reuters prize-winning picture from 2011, but it really stresses the importance of thinking through the distal effects of this data stream that we're creating. We don't want to create a digital version of this in these low-resource populations. So with that, I leave you with the concept that the world is more increasingly connected than it has ever been before, and it's really the opportunity that stands before us to harness to improve lives for mothers and children globally. So thank you very much for this opportunity.
Good morning. I'm so excited to be here today to talk with you all a little bit about kind of a deeper dive into a mobile health program called Text for Baby that's really being used to kind of, improve maternal and child health in the U.S. So just to give you kind of a quick summary of the program, Text for Baby is a free text messaging service of the nonprofit, the National Healthy Mothers, Healthy Babies Coalition. We're currently the largest national mobile health initiative, reaching over 635,000 individuals since the service launched in 2010, February of 2010, so just about 3.5 years ago. And so through these free text messages, pregnant women and moms with babies under 1 receive customized health and safety information and public health alerts that can support them in achieving key developmental milestones and help give their babies the best possible start in life. So with this program, we're aiming to reach traditionally underserved populations, low income and young women, particularly those identifying as Hispanic or African American, as research shows that these are the women who are at a higher risk of having disproportionately poor birth outcomes. The program really is kind of an example of a true public-private partnership, so kind of bringing together stakeholders from both private and public sectors, really with a vested interest in maternal and child health to help make a difference. So Voxiva is the technology company who kind of helps run the technical aspect of the program. They had been doing a lot of work overseas and really wanted to come back to the US and implement a scalable mobile health initiative here, and really saw the opportunity in the maternal and child health field. Reached out to the National Healthy Mothers, Healthy Babies Coalition. So we are the nonprofit home maternal and child health kind of expert nonprofit organization, really kind of convening a lot of the partners that have helped keep the program going. Johnson & Johnson is the founding sponsor of the program. We've worked very closely with the Wireless Foundation, so they've been integral at kind of convening the mobile carriers who have, in a very unprecedented way, kind of come together to donate free text messages to the program so that it truly is a free service. A woman will not be charged in any way for the messages that she receives through Text for Baby, which has also kind of allowed us to reach even a broader population as well. The Department of Health and Human Services has also been involved both kind of in the content development, so the Centers for Disease Control and Prevention has been very much involved since the beginning in kind of helping develop the messaging, but also in helping spread the word. The White House Office of Science and Technology Policy was also a founding partner, as well as Gray Healthcare Group, who kind of helped with some of our marketing and communications. The true power in Text for Baby really kind of lies in this vast network of partners. So, more than 1,000 organizations and individuals from around the country have really come together to help spread the word about this free program to the women that they serve. So everything from those federal agencies that I talked about to state and local health departments, Medicaid agencies, health plans, national nonprofits, the major medical associations, hospitals, federally qualified health centers. You name it, kind of anybody with a vested interest in maternal and child health has really gotten involved to help spread the word about this program. And this has kind of already been set today, the stage for why go mobile, why use a technology like this, and specifically text messaging. It's important to look at kind of the population that we're trying to reach and see that not only do they have cell phones, but they're also texting at high rates. So we know that females text more than men, people of color are more likely to text than their white counterparts, and low-income Americans text more than higher income. We also know that there's a very serious problem when it comes to maternal and child health in the US. So every day, over 11,000 babies are born, and of those 11,000, nearly 1,500 are born preterm, 964 are born with a low birth weight, and 78 babies die before their first birthday. And the infant mortality rate in the US is one of the highest among developed nations. there is a real need for a program like this to exist. I mean, even more startling than kind of those initial statistics are when you look at kind of the disparity. So African American babies die at a rate more than twice that of their white counterparts. Puerto Ricans have a low birth weight that is 60% higher than the rate for non-Hispanic Caucasians. And Mexican American mothers are 1.9 times as likely as non-Hispanic white mothers to begin prenatal care in the 3rd trimester or not receive prenatal care at all. And we know that many factors contribute to these negative outcomes, including lack of access to prenatal care, negative health behaviors such as smoking or substance abuse, poverty, unsafe sleep for baby, etc. So ensuring that pregnant women are well informed about their pregnancies and connected to available health resources, and of course getting connected to prenatal care can really help. So the Text Your Baby program really kind of leverages mom's cell phone to do just that, to really be that connector for her. So the Text Your Baby program, it's very simple to sign up. So a mom does not need a smartphone to take advantage of the program. She'll simply text the word baby or bebe to the short code 511411. So the program is available in both English and in Spanish. She'll then be prompted to give her due date or baby's date of birth and her zip code. She'll then get 3 messages a week that are timed to where she is in her pregnancy or how old the baby is. So it's all tailored, relevant, educational information, really just designed to keep her and baby healthy through pregnancy and then through baby's first birthday. The content is, very important to us, the integrity of the content, and we work very closely with, as I said, the Centers for Disease Control and Prevention, but also a number of the major medical associations like the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, among others, to make sure that the topics that we've set are the ones that need to be covered, that messages are timed appropriately, and that it's the latest science. You can see here kind of just some of the topics that are covered through Text for Baby. This is certainly not an exhaustive list. Another kind of key element to the program is our ability to send critical health alerts. So you can see here kind of a list of some of the things that we've been able to send information within 24 hours, on Tylenol recalls or a carbon monoxide poisoning, in response to power outages in Connecticut and Massachusetts. Everything from car seat safety guideline changes, pertussis outbreaks. We're able to send this information in a targeted way, so it can either be national, if it's a national alert, or targeted to the state and zip code level. And that's kind of, again, the true benefit of having this technology is being able to pinpoint it to a location and also to get it out in a scalable and quick way. Since the program launched 3 years ago, we've really tried to introduce some interactivity into the service. So when it first launched, it was pretty much a one-way messaging system. We were able to send the educational information, but weren't really getting much interaction with mom. Since then, we've really kind of gone through and added some opportunities for interactivity, including additional opportunities for moms to text more to get additional information on topics that are of interest. To text to messages that they like, so we can kind of get more real-time data on the messages that are resonating with moms. Additionally, we have added mobile web pages. So while we know, not everybody has a smartphone, the statistics show that that is increasing. So 160 characters is a very short amount of space to get this critical health information out. So the mobile pages, which have been developed in partnership with our content partners, so the major medical associations and the federal government, really kind of allow for some additional more in-depth information, links to videos and things like that, which we've found is really beneficial to our user base. Additionally, kind of adding an appointment reminder service, which I'll talk a little bit more about in a second, as well as quizzes, so kind of asking a question and having real-time kind of interaction with the topics. So this is just kind of an example of what the mobile pages look like. So the text message is all the way on the left there, with the link to the mobile page, which is then taken to our mobile website with kind of additional information. And this one, is specific to the importance of getting to 39 weeks. And so we link to kind of March of Dimes campaign around 39 weeks in the video that they have associated. So this appointment reminder feature that I mentioned is one that we're really excited about, and one that was actually, kind of the idea for it was kind of conceived with some of our partners who really expressed to us that retention was a big issue for them, and making sure that they were getting moms into appointments was a big priority. So, what we're able to do is a mom can text the word remind or cita in Spanish. She's then prompted to text in her appointment date as well as a brief description of what the appointment is. So is it her prenatal appointment? Is it a WIC appointment? She can put in that information right there. She then receives a reminder 3 days before the appointment as well as the morning of. So, we've heard a little bit from the other speakers today about the importance of kind of evaluating efforts and really understanding the data behind these programs, and Text Your Baby truly is a data-driven initiative. We're able to kind of collect a lot of information through the service itself, in addition to some of the external evaluations, which I'll get into in a moment. But through kind of the information that we're able to collect directly from the service, we know that Text Your Baby is reaching individuals early in their pregnancy. So of the users who have signed up to receive pregnancy messages, over 47% enrolled during their first trimester, which is great. We're connecting with them early, getting the information about how they can connect to prenatal care if they don't have a provider, means that they're getting all of that information very early on. We also know that Text Your Baby is reaching women in high poverty areas. So this is, we use zip code as kind of a proxy to compare to census data. And a higher percentage of Text Your Baby users live in zip codes with the highest levels of poverty compared to the overall US distribution. We're also able to get a sense for user satisfaction with the service. So we do have a survey that we send out asking if Text Your Baby users would refer the service to a friend. And 93% of users who respond to that survey said that they would, and rated the helpfulness of the service as a 7.8 out of 10. Some of our external partners have also conducted these kinds of studies with their patients, and a short survey conducted with patients at Carillion Clinic in Roanoke, Virginia, found that 92% of women who continued to use the service were satisfied with the program. Similarly, an evaluation conducted out in San Diego found that 8.5 out of the satisfaction rating for users who participated in their study was an 8.5 out of 10, with Spanish-speaking users reporting a higher level of satisfaction. So this indicates to us that text messaging, mobile health initiative is something that mom is resonating with mom, and she likes it. It's reinforcing kind of the value of the service for the user. We also, kind of, as I mentioned, have introduced this interactivity. Kind of our first foray into interactive modules was through our flu module in 2011, and we've since replicated that in 2012 and 2013. But the first kind of what we wanted to get out of this was to understand if our user base was engaged and if they were willing to kind of answer questions about their health. So we sent a message to all of our users in October of 2011 asking about their intentions to get a flu shot. And what we found was that 31% of users responded to that survey. And so this was in real time. We asked the question, and within 24 hours, 31% of the active user base had responded, letting us know one way or the other about their intention of getting a flu shot. So respondents planning to get the vaccine were also asked if they wanted to receive a text reminding them to get the shot. So 55.7% of those who responded asking if they wanted to receive a reminder replied yes. And nearly 3/4 of respondents who were not planning to get the flu shot were willing to provide a reason why not. And we were then able to follow up with kind of tailored educational messages based on their reason for not wanting to get a flu shot, and also information about where they can get free and low-cost flu shots. So the information that we kind of learned from this 2011 study really kind of helped inform our 2012 module, which was really kind of more of a research study, and we do have those evaluation results kind of coming out the end of this year. They'll be presented at the mHealth Summit. So this is kind of another example of really kind of the interactivity and being able to collect information and provide resources related to healthcare and health coverage. So we partnered with the Centers for Medicare and Medicaid Services to kind of develop this message track. One, to identify kind of who our user base is. So we were able to use this as a way to assess kind of, again, if we're reaching the target population. But more importantly, for those who identify as uninsured, we were able to send a message right away after they indicated that they were uninsured, that, where they could go get free or low-cost health coverage. So using kind of the Insure Kids Now hotline and website, where individuals could go to get more information on those programs. So a week after we sent that initial message with the resource information, we followed up to ask if the individual had gone ahead and started the application process for Medicaid or CHIP. So as you can see here, kind of the 13% is the uninsured population, and 51% reported that they had begun the application process. So, this again kind of indicated to us that, people are taking action based on kind of some of the resource information that we are, sending through the service. This is self-report, so of course we are looking into kind of a more qualitative study around these data to identify, what's really going on here, but definitely very encouraging preliminary results. So I did mention there are a number of external evaluations that are currently being conducted or have been conducted on the service. So the National Latino Research Center out in San Diego conducted a survey with moms, which have some results that I'll talk about in a minute. The George Washington University did a pre-post survey, a randomized trial in Fairfax County, which I'll also talk about in a moment. Emory University did a pre-post survey with WIC recipients in Atlanta. The two kind of largest evaluations that are being conducted currently on the program are both being funded by the federal government. So the Department of Defense is funding an evaluation at Madigan Army Medical Center in partnership with George Washington University. And this will actually be a randomized controlled trial, really looking at kind of behavior and knowledge change. They are in the process now of kind of finalizing, they've collected all of the data and are in the process of analyzing and putting together their report. But we're expecting kind of results early 2014 from that evaluation. Similarly, the Department for Health and Human Services funded Mathematica Policy to do another national evaluation targeting 4 communities, also looking at behavior and knowledge change. And then the University of Maryland School of Public Health Center for Health Literacy did a small study to kind of analyze the Text Your Baby content to see how it aligns with health communication theories. So these are just some preliminary results from some of these evaluations. What we've seen from these evaluations is that Text Your Baby is increasing health knowledge and preparedness. So in that San Diego study that I mentioned, 74% of participants reported that Text Your Baby messages informed them of medical warning signs they didn't know. The GW-led randomized evaluation in Northern Virginia found that Text Your Baby mothers were nearly 3 times as likely to believe they were prepared to be new mothers compared to those in the no exposure control group, really kind of speaking to the self-efficacy component to the program, really kind of feeling like it's a support to them and helping them feel prepared to be moms. The San Diego evaluation also looked at appointment attendance and found 65% of participants reported that Text Your Baby helped them remember an appointment or immunization that they or their child needed. And finally, kind of helping to facilitate interaction with health providers and improving access to health services. And this is a really important one for us because we really see Text Your Baby and kind of these mobile interventions as being complementary to the healthcare provider and really trying to reinforce that relationship. So the fact that Text Your Baby in this study seemed to kind of be empowering moms to talk to their provider was something we were very excited to see. So we just have a couple of upcoming opportunities for further research. So NIH has granted Text Your Baby a contract to look at developmental screening and demonstrating kind of the feasibility of a text-based developmental screening tool. So that will have kind of a final report coming in March. We've also recently been awarded a contract from the Centers for Medicaid and Medicare Services to deploy a pilot in 4 states, really kind of focusing on expanding efforts to enroll mothers in Medicaid and CHIP into the service, but then to also assess Text Your Baby's impact on improving key quality measures. So there will definitely be an evaluation component to this as well. The next couple of slides just kind of really focusing on how we're working with providers and with healthcare, the institutions, to spread the word about Text Your Baby. So really getting it integrated into outreach and enrollment, communications. You can see kind of, Medicaid mailings to participants, buck slips in birth certificate mailings, And then really kind of getting integrated into some of the core processes. In Oklahoma, they'll be adding a link for enrollment to Text Your Baby onto their Medicaid application. Thinking about electronic health records and how prompts can be added for providers to remind them to enroll individuals into Text Your Baby and things of that nature. And then just some easy ways to kind of integrate Text Your Baby into the clinical environment. We always encourage individuals and organizations to become partners with us. We provide technical assistance as well as free materials that can really help remind you to talk to your patients about the program, as well as a number of other resources. So I hope that this was interesting, and that if you have any questions, I'll be happy to answer them now.